Good morning, everyone. Today, the topic for presentation is heme catabolism. I'm Professor Biochemistry Dr. Bhagyalaxmi speaking on this heme catabolism. How this catabolism is going on. The RBC lifespan is 120 days. After this, they are degraded by reticuloendothelial system. Here, the RBC they're getting lysed and hemoglobin getting released, heme part this side and globin part one side. Globin part is getting converted to amino acids and they are released. Coming to this heme part, in the presence of heme oxygenase system, that is oxygen, cytochrome C, and within this only NADPH has got good role, and this ring is getting opened. With this, iron is liberated and carbon monoxide also released, and we are getting biliverdin. This is one of the bile pigments. Here, the opening of ring, and this biliverdin is getting converted to bilirubin in the presence of the enzyme biliverdin reductase. Here, NADPH has got vast role, and which is from heme oxygenase system. This is getting converted to NADP. This is NADPH. This is one of the important compounds from Hme pathway. It has got major action here, and finally bilirubin is formed. Overall, if we see for the generation of bilirubin, microsomal heme oxygenase system, NADPH, molecular oxygen, and biliverdin reductase, they are taking part. And any abnormality in the liver affects this process and leads to jaundice. The porphyrin ring is broken down in the reticuloendothelial cells of liver, spleen, and bone marrow to bile pigments. These bile pigments are biliverdin and bilirubin. And about 6 grams of bilirubin is broken down per day, and from which 250 milligrams of bilirubin is formed. And also from myoglobin in the muscle, myoglobin and other heme containing proteins, around 50 grams is formed. So totally 300 milligrams per day is produced. 80% is from destruction of RBC, hemolysis of RBC, and 10% from ineffective erythropoiesis. And rest 10% is from degradation of myoglobin and other heme-containing proteins. Even free hemoglobin and heme are liberated by lysis of RBC, and haptoglobin and hemopexin, and they will bind and prevent the excretion. About this microsomal hemoxygenase system, heme is degraded by this system and it requires NADPH from Hme pathway and cytochrome C. This is required for regeneration, and this system catalyzes the cleavage of alpha methynyl bridge, which links first and second rings of pyrroles. And this bridge is liberated as carbon monoxide. And the Fe2 plus is getting oxidized to Fe3 plus and taken up by this linear tetrapyrrole formed is biliverdin, that is green in color, and in mammals to bilirubin by biliverdin reductase. This is the enzyme which is very important, and this is NADPH dependent and radiolopigmentosis. Next, transport to the liver, how it is happening. And the bilirubin formed in the reticuloendothelial system is insoluble in water. and the formed bilirubin is transported in plasma and binds with albumin. That's one of the important plasma proteins. And one molecule of albumin can bind 2 molecules of bilirubin. 100 ml of plasma can transport 25 milligrams of bilirubin. And when excess can easily dissociate from albumin, and the binding sites can be occupied by aspirin-like compounds. Such drugs can displace albumin from bilirubin. And kernicterus is one term. And when the bilirubin level crosses more and more and raises more, that crosses blood-brain barrier and causes kernicterus in children, newborns, which is very dangerous to the baby. And this, after combining with albumin, this complex reaches the sinusoidal surface of the liver and binds to hepatocyte membrane and releases bilirubin. That enters the liver cell, and next conjugation process takes place. And bilirubin in the cell binds to cytosolic proteins. They are ligandin and Z protein. And ligandin also possesses enzyme activity, and it involves in detoxification process. Inside the cell, conjugation with glucuronic acid to make it water soluble, and drugs like anti-malarial drugs, primaquine, and certain antibiotics, novobiacin, chloramphenicol, and certain hormones, also androgens and pregnenolone, they interfere with this conjugation process and cause jaundice. After this, excretion into the bile is the process, and this is the active process, occurs against a concentration gradient, and this is the rate limiting step, and induced by phenobarbital. This is mediated by ATP binding cassette protein called multi-specific organic ion transporter, that is MOUT, located in the plasma membrane of biliary canaliculum. The conjugated bilirubin now it reaches the interstitial cells and by here intestinal bacteria deconjugate the conjugated bilirubin. The free bilirubin that is further reduced to colorless UBG compound, urobilinogen. And with further reduction of UBG that leads to mesobilinogen and stercobilinogen. This is mostly excreted through fecal matter. Around 250 to 300 milligrams per day is getting excreted. Next, coming to this enterohepatic circulation, 20% of urobilinogen is reabsorbed from the intestine and returned to the liver by portal blood. This urobilinogen is re-excreted through enterohepatic circulation. Since UBGs pass through blood, a small fraction is excreted in urine, that is around less than 4 milligrams per day. The amount of urobilinogen excreted, that is serving as an index of rate of bilirubin formation and transfer. See, this is enterohepatic circulation. Heme is getting degraded to bilirubin, next combining with albumin and forming bilirubin-albumin complex. Then in the liver, here the conjugation process takes place, and from that getting transported to bile duct. Here bilirubin diglucuronide formation, monoglucuronide first with conjugation and then diglucuronide. Next, entering into small intestine and large intestine, formation of stercobilinogen and stercobilin around 300 milligrams. But here part of it urobilinogen through the blood, through the vascular system, entering into the liver. So enterohepatic circulation, this is. So from this, again, part of it, this urobilinogen the blood enters the kidney, and as urobilinogen getting excreted through urine. And transport to the liver, albumin and conjugation in the liver may compound glucuronic acid. And UDP glucuronyl transferase is the enzyme here. And we need to remember the drugs, primaquine, antibiotic, chlorpheniramine, obesin, and hormones, androgen and pectinidine here. When the patient, if the patient is on such. An excretion of bilirubin to bile, that is the active process. Against concentration gradient, it is taking place. That is a rate limiting step and multi-specific organic and anion transporter. So conjugated bilirubin is reaching the intestine through bile. Intestine and bacteria deconjugate it, and free bilirubin is reduced to urobilinogen. Here, about the fate of bilirubin. Here, bilirubin conjugation. To bilirubin monoglucuronide and diglucuronide. Here, the glucuronyl transferase is the enzyme, two-step process, and the glucuronic acid, UDP glucuronic acid here. And then this is the conjugation process in the liver. And metabolism and excretion of bilirubin occurs in liver and intestine. And uptake by liver parenchymal cells, conjugation and smooth endoplasmic reticulum in the liver, secretion of conjugated bilirubin, then excretion of bilirubin in the form of stercobilin and urobilinogen through fecal matter and urine spectrally. See, this is the picture from hemoglobin, globin part got removed, heme released, and this is also produced from other proteins, myoglobin, peroxidases, and cytochromes. Near this degradation, bilirubin transporting and combining with albumin, giving rise to bile pigments bilirubin, and here the conjugation process, next secretion process and excretion process, and urobilinogen, and through fecal matter, stercobilin, and through kidney, this urobilin getting excreted. This is enterohepatic circulation, again part of it. And shunt bilirubin, little about this, and formation of bilirubin from heme in bone marrow without being incorporated into hemoglobin. And this is the result of ineffective erythropoiesis, resulting in effective erythropoiesis in porphyrias, especially in erythropoietic varieties. This shunt bilirubin is released. And this is the graph here. And this is with the radio labeled compound and the radioactivity with this. With the bilirubin, this is about 15%, and hemoglobin in RBC, that is this red one, and days after radio labeled injection, this is, and here about 85%. And the estimation of this bilirubin, we are doing Vandenberg test, and here the diazo reagent is produced, that is called azo bilirubin, that is, and bilirubin is combining with this diazo compound here, and conjugated bilirubin being water soluble gives the color immediately, that is direct reaction, and free bilirubin water insoluble to be excreted with the alcohol. And this biphasic reaction means immediate and after adding ethanol, both reactions will be positive. That is called biphasic reaction, usually seen in hepatocellular jaundice. And a normal serum does not give positive Vandenberg. And what are the tests we do for bile pigments means urobilinogen and stercobilinogen, they react with earliest reagent to form red color. That is one test, and Fauchett's test is one, and Mellin's test is another one. And Schlesinger's reaction also, that is one of the things. And urobilinogen, sterobilinogen, they form complexes with zinc ions and which exhibit brilliant green fluorescence in the Schlesinger reaction. This is negative for normal urine. And differences between these two, uh, free bilirubin and conjugated bilirubin. Here this is insoluble in water, insoluble conjugated one, and both are soluble in alcohol. Plasma levels up to 0.6 milligrams here. This is 0.2 milligrams per deciliter. And urine, this is absent in both. And absorption, this is not absorbed, whereas this is absorbed through GIT. And diffusion diffuses into tissues. And Vandenberg test. And the indirect positive, this is direct positive. Um, these are the disorders related with hemoglobin catabolism, which will continue in the next class. The disorders of this.